foveoschisis.
Thank you, Professor Claver and Professor Tadayeni, for the invitation. So what happens to these patients that are not operated? I remind you that myopic macular schisis concerns about 1/3 of myopic eyes and results from the preretinal tensions in the concavity of a macular staphyloma in most cases. We know now that surgery is safer with the advance in vitrectomy and dyes, and that postoperative macular hole occurrence is lower now that we use fovea sparing technique, and probably because we do not wait for advanced foveal detachment cases. Intraoperative OCT has helped us guide the ILM peeling techniques and also check the retina in the surgery for macular hole. And we published a paper in 2017 saying that we should not wait for a loss of vision lower than 20/50 to obtain the best visual outcome in myopic macular schisis. But what about these patients who have a visual acuity over 20/50 and that we do not operate? So we selected this specific population in a cohort of myopic macular schisis that were followed up more than 6 months, and we excluded, of course, patients having visual acuities lower but not operated because they had advanced glaucoma atrophy. And we observed that 2/3 of the patients still had a visual acuity over 20/50 at the end of the follow-up, and 32 of them had either surgery or their visual acuity dropped. During the mean follow-up was about 3 years, so we took this mean follow-up and observed at 3 years who has worsened, how many, and 72% of patients had not worsened in visual acuity after 3 years of follow-up. Also, we wanted to know what defines, what influences the visual acuity. So first we said, okay, in macular edema, we have a correlation between central foveal thickness and visual acuity. Let's see if it works. And here, it doesn't work. There's no correlation between the central foveal thickness or subfoveal thickness and the visual acuity of these cases. So what's the difference between this case that keeps his visual acuity and this case that worsens? So we looked at this specific group that worsened and to see what's happened between the first visit and the last visit. So indeed, we had an increase in the central foveal thickness and in also a decrease of the choroidal thickness, but we observed significantly a defect of the outer retinal layers that were worsening between the first visit and the last visit. So probably the changes in the outer retinal layers may affect the visual acuity more than the central foveal thickness. But we also observed that some myopic schisis may also improve without surgery, probably due to changes of the vitreous. We had a series of 14 eyes representing about 20% of non-operated myopic macular schisis, and the vision was good, as I told you, and in this small group, 2/3 of these patients had a complete resolution of the macular schisis, and also when a foveal detachment was present. And interestingly, 36 of patients presented also with myopic CNV. And we observed, again, in 2/3 of cases, that vitreous detachment progressed or changed, either from no detachment to perifoveal detachment or completely detached, as you can see in the first case. And in 5 cases, no vitreous changes were observed, but as you know, even with these amazing wide field OCT scans that we can have with Canon, we see the vitreous, how it is attached, but our understanding of how it creates tensions on the retina is not fully understood. But we can see that it's more complex than just detached, partially detached, and that vitreous in myopic eyes is very abnormal. And in the 5 cases with CNV, I will give you an example. This patient had a CNV, was treated, followed up, and we observed the onset of a myopic macular schisis. And at a point where we were kind of discussing surgery, she came with myodesopsia and her vitreous was detached. And then the schisis resolves spontaneously. So this has also been described in a very recent paper that onset of macular schisis can occur in 16% of eyes with CNV, and that spontaneous resolution was observed in around 6%. So both situations can be together. So in conclusion, myopic macular schisis with a visual acuity over 20/50 may be observed for a few years, and the disruption of the outer retinal layers may affect visual acuity more than the thickness. We also know that now that improvement of macular schisis without surgery is possible in about 10% of cases, and I think we should consider a time of observation before surgery is recommended, especially if you see a vitreous detachment. Modification of the vitreous may be the main pathogenesis mechanism in these cases, and the modification of them may resolve the case. Thank you.
Thank you. This paper is open for discussion. Please go ahead.
Thank you very much. In these patients with macular schisis with OCT evidence of vitreomacular traction, some of the cases that you showed, there is partial BVD, and there is still vitreomacular traction. If you decide to operate, do you still need to do ILM peeling or just separation of the posterior hyaloid?
That's a very good question. There are series in the literature that report a good outcome after surgery with only vitrectomy.
And separation of the posterior hyaloid.
Yeah, but that's a very good point, actually, because in some cases you might need not only to remove the vitreous, probably in these kind of cases that could resolve spontaneously. The cases I presented is a very young patient, amblyopic, who was not eager to go to surgery and had also the periphery of the retina was really pathological, so I didn't want to operate him either. That worked very fine for me. But indeed, this case could benefit probably only from vitrectomy, in contrast with older patients for which the vitreous seems detached or at least really liquefied, and there is lamellar hole or foveal detachment membranes. These cases might probably benefit from ILM peeling. The other consideration is maybe to think about what is the degree of posterior staphyloma, because we explained it in the several talks that it's the adding of the vitreous traction, of the tensional thickening of the inner limiting membrane and the posterior staphyloma. So if we don't treat everything in a narrow staphyloma, maybe the patient will not benefit for only vitrectomy.
Okay, thank you.
Yeah, I did wonder, what is the relationship with age? Do you see any differences in the older and the younger patients?
So I have 3 cohorts of patients, the operated and the more follow-up. I did not perform yet a comparison strictly statistically accurate to answer, but I observed that indeed the age was a little bit older in operated patients.
Mm-hmm. Yeah. Okay, thank you very much. So it's a pleasure for me to announce the